I now invite the Amitabh Bachchan of ophthalmology, Dr. Amar Agarwal, who all of you know is just not a brilliant surgeon, but a brilliant innovator. And that's what sets him apart. And I don't know, some of you know, he was voted the second most popular ophthalmologist in the world. And that was phenomenal, Amar. And please take over.
Thank you very much, Kumar, first of all, for this lovely course which he holds every time in here, ASCRS everywhere. So let's see two cases. First case, pseudophakic bullous keratopathy, anterior chamber IOL inside. So I make my scleral flaps, as you can see here. Once I made my scleral flaps, I prefer to make a scleral tunnel incision because obviously that AC IOL has to come out. Now the cornea is so bad, so what I'm going to do is take off this bad epithelium there. Once it's there, I see slightly much better. I fixed fluid in the eye. Now what happens is, I make my flap, but I'm worrying that they are not exactly 180 degrees apart. So I'm just adjusting it, make my sclerotomies. Once that's done, I'll do my vitrectomy, which you're seeing me do just now. Now, once I've done my vitrectomy, I always go in and see the posterior segment because I do not know if the previous surgeon has dropped a nucleus, IOL, anything inside, which can happen. Extend my incision. Now take out this IOL. This has got some 4 haptics inside, so we need to take them out very carefully. And the issue is they get sometimes stuck to the iris. You see there, it's stuck to the iridectomy there. Here again, I'm removing the second one. Once it has come out, it might come out broken also as it has come out here, but I still got 1 haptic inside the eye. So you can see there, 1 more haptic is there. Now still, the broken haptic removed. Now this last one is got stuck to the iris there, and I'm just slowly and carefully bringing it out. My fear is if I rip it too much and the iris rips, the bleed will happen. Little bit of bleed happened, not much, so it's okay. Anyway, so far so good. Done vitrectomy some more. Now the issue is I need to fix a lens in it. Obviously there's no capsule, so we use a glued IOL technique. I'm using it like a non-foldable IOL because I already have a large incision. Once 1 haptic is in, now I go in with a second haptic, do the handshake technique, transferring it from one hand to the other and externalize. Now look, both haptics are out. See the amount of haptic externalized, it's a lot. There's no way this lens will dislocate or sublux. So now tuck it into the chariot's pocket. Once that's done, now I want to make the pupil smaller. This is a technique which is called the 4-throw pupilloplasty, single pass 4-throw pupilloplasty or SFT. So this is just the animation. If someone has not learnt it, please move into this because all you do is 4 throws and that is game, set and match. So in this case, I want to make the pupil a bit smaller. Here you can see I'm making the pupil smaller, passing the needle from one end to the other, railroading it, bringing it out. You can see this is the single pass. Once that's done, I'll put it 4 times the loop. That is the single pass. Now it's 4 throw and pull on both ends, and that completes this case. Now once you have done that, then we can move on to the next phase of the surgery. Once the pupil is small, the advantage here is if any closed angle is there, it becomes open. Look, I'm also injecting air inside. Now I create the P-deck bubble. So this is the pre-descemet's endothelial keratoplasty, not dissect, not Dmek. The advantage here is I can use young donor eyes. The second big advantage is these P-deck grafts don't detach. In Dmex, you'll have at least 25 to 30%. In this, you have about 3% only. Now I put a trocar ACM, AC maintainer, got air inside. Now I remove the endothelium descmes complex. You remember how bad the bullous keratopathy was? Once that is removed, my next step is to do the injection of the P-deck graft. Just load it into the injector, inject it inside, unroll it, and fix it with air. Now let's see how this patient behaved once I have unrolled the graft. Here you can see I'm injecting air under the graft there, unrolling it, fixing it fully so that the graft is well centered. The advantage in P-deck, ladies and gentlemen, is it will also move exactly where you want it to, not like a Dmek graft. Apply the glue, seal everything down, and you can see how the case looks when completed. So let's see now at the end of the case how the patient looks. This is at the end of the case, the patient looking. Let's see the post-op pictures also for us to analyze how this patient has done. So this was the pre-op. 2 weeks post-op, vision improved to 636. 1 month post-op is 618 already, 69. And now you will see the final picture here, 3 months post-op, ladies and gentlemen, 20/20 vision. You can see the pre-op and the post-op. I'll show you one more case and then I'll give it to Kumar again to move into it. Now this particular patient was a top actor. He had come to me from Poland. And I don't know how he was acting with such a bad cornea, but look at the iris. It is so badly damaged. So now I know I have to fix the iris and also fix the pediatric graft. So I make a scleral groove. I'm taking off this epithelium. Now once I've taken off this epithelium, now you see slightly better. Now the technique which we started to fix an iodialysis is the trocar assisted iodialysis. So here you can see I'm fixing a trocar AC maintainer. I've got fluid in the eye. Now wherever the dialysis is, right opposite it, you fix another trocar. Look at the trocar, it's a blue color one, that means it's 25 gauge. Okay, so right opposite the dialysis, I'm fixing my trocar AC maintainer there. Once that trocar is fixed, I will use this to fix my dialysis. Now the method is, this is a modification of hangback technique by Michael Snyder, but the principle here is very simple. I'm going to now use a double-armed Prolene needle. So you pass the double-armed Prolene needle, it goes like that, goes through the iris, that iodialysis portion you can see there. Once it's done, from the other side, you can bring a 30 gauge needle from the sclera. Now railroad the two, okay? Once you have done that, bring it out. So this is the first arm of the double arm Prolene. Now same thing you will do on the other side using the second arm of the double arm Prolene. So here you can see the first one coming out. Now I go in and do the same for the second arm of the double arm Prolene. So you can see I'm passing this inside. Once that's inside, again I'll pass it through the iris there, trying to fix the iodialysis. Remember one thing, in such cases the dialysis is quite bad. It's not a small amount of dialysis. So you have to be realistic how much you can fix also. Here you can see I'm passing it again through that iris tissue. I'll again bring it out through the sclera, through the railroad technique which I just talked to you about. Now all you do is pull on both ends, and you pull both the sutures, this dialysis will start getting repaired. So this is the trocar assisted iodialysis technique. Look, I'm pulling on both ends and you can see the dialysis getting repaired. Remember one thing, when you start repairing a dialysis, obviously the pupil will get decentered. So here you can see I'm fixing the dialysis somewhere in another area, and the principle is, once that's done, I will now add a pupilloplasty in it. So this is the twofold technique. In other words, I'm combining the trocar assisted iodialysis with the pupilloplasty. Here you can see the remaining second portion of the iodialysis being repaired. So this is the second arm there. Again I'm pulling it inside and solving it fully there. Once the iodialysis is repaired, now let's move on whether I can repair the problem of the peripheral anterior synechia. You see that I'm trying to break the peripheral anterior synechia there, because when I do the pupilloplasty, the closed angle will become open. So that's my game plan here. I'm trying to break it with a rod now. With the other hand, I'm trying to pull on it so that the peripheral anterior synechia are broken. But if you don't fix it with the pupilloplasty, the synechia will form again. So here you can see now I'm passing the Prolene needle through the iris to create the effect there. Remember, now what am I trying to do? I'm trying to do a twofold technique. I just did the trocar assisted iodialysis. Now I'm combining it with the pupilloplasty to do this twofold technique. So basically a twofold combines these two techniques there to get a better pupil. Once I have done that, you'll see the pupil coming back into shape comparatively better than what it was before. Remember, this patient has come to me all the way from Poland. He's one of the top actors there. I cannot go wrong, okay? Because obviously he's a big shot, there's no discussion on that, but also he's come from another country, so obviously I will have problems if he has to come back to me. So here you can see now I'm fixing this photoroplasty, somewhere on that side. Important issues, look at the Purkinje image, it's on the iris. So at that stage, you can take a vitrectomy probe and just enlarge the pupil to make it more centered. So help to make the centered pupil so that the Purkinje image P1 falls on the pupil center. And you can see that happening now. Once that's done, all I need to do is shift to air. Because once I have air inside the eye, I can remove the endothelium desmase complex to do the PDEC graft. So here you can see I'm removing this endothelium desmase complex. Once everything is there, here you can see I'm preparing the PDEC bubble, PDEC graft prepared. I will now inject it inside, and let's see how this patient behaved at the end of the day. So that's what we did here in this case. The case I showed you just now was to show you the trocar-assisted iodialysis, followed by the photoroplasty, and also ending it with the PDEC technique. So here you can see the ending of this particular case, which I'm going to show you. I'm going to unroll this graft. Once the graft is unrolled, I have continuous air infusing inside. I will now unroll that edge of the graft also finally. Let's see how this patient behaved in a second there. And that's how the case looks when it is completed. This is the patient post-op day 3, 6/18, and you can see the patient vision has improved to 6/6 here. Preoperative hand movements to 6/6. I'd like to thank Kumar once again for this invitation, and I want to thank all of you once again for being here for this course. Thank you very much.
Any questions? Because I think Amar and both might leave the hall, so anyone wants to ask him. So I think you were the first doctor in the world to do PDEC, am I right?
That's correct.
So the idea
We did
was
this with the help of
given to
Harminder
you-
Dua.
I
have
know,
to give
so
credit to
you were
her.
discussing with him with
Yeah.
Dua, and then it struck you, why not you do it?
Yeah.
So just for the information of the house, he was actually the first surgeon in the world to do PDEC, which is now become a normal norm in corneal surgery. Congratulations to you and your team.
So one question, how long did it take for you to finish the surgery?
How many days?
But
You
this
should
would
ask
have,
how many days?
because this would have lasted easily 3 hours to 3-4 hours.
उतना तो क्या करूँगा?
This is amazing, sir.